this week on the Backtable Podcast.
Sometimes you just can't get into the level that you want, and it's okay. It's perfectly
totally
fine
agree.
to kind of pull back and aim for the level above. You don't necessarily even need to come back to the AP to do that, but as long as you mind your trajectory and you come back and you just aim for the level above, you're usually going to be okay doing that, and that's totally fine. But I would say 90% of the cervical epidurals I've done interlaminar and at C6-7, mostly C7-T1, sometimes C6-7, and sometimes T1, T2.
The first couple of cervicals that I did, I find like counting the levels, like it wasn't always like as straightforward. Like it took me a while to get my like pattern recognition as far as like what T1 looks like and what C7 looks like. I'm having trouble like putting it into words other than like the orientation of...
I agree too. It's very confusing.
Hello, everyone, and welcome to the Backtable MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the spine jack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show. Welcome back to part 2 of our discussion on epidural injections with Dr. Chris Beck. If you haven't already listened to part 1, check that out first before listening to this one.
You know from looking at CT that the contrast and the medication really goes all over. So I don't actually feel that the selectivity of the transforaminal epidural injection is that much more than the interlaminar. That may be just total heresy to any of our pain colleagues listening, and I apologize for it, but I do think that that is true. But, you know, I definitely don't fault anyone who would use a transforaminal, particularly for a lateral or foraminal disc herniation. You know, the idea that you're going to get the greatest concentration of medication there, I think that's totally fine. But for me, I prefer just to stick with the interlaminars. And so if the transforaminal approach is a little bit different, so you go quite a bit more oblique and be using a 22 gauge Quincke needle. So rather than a 2E, the reason for this being that you're not really, unless you're just completely off, you're not going to get a dural puncture through a transforaminal. You can, but I think you'd have to be significantly off. And so if you look for this, there's both supraneural and infraneural approaches to that, basically going above or below the nerve root. I think different people have different preferences. I think the supraneural is probably a little more common. And so for that, on your oblique AP view, you're going to target kind of just under the chin of the so-called Scotty dog. And so you're kind of aiming for just under the pedicle, and you'll insert it in and then come back to an AP. And I would say this, especially if you're not used to doing it before, switching between an AP and lateral is good. And the kind of safety zones that you're looking for the lumbar transforaminal is on the AP. You don't want to go past the mid-pedicular line. So kind of the 6 o'clock position on the pedicle above. And on the ventral, you don't want to go ventral to the epidural space. And for obvious reasons, you could end up accessing the disc. And I will say, related to that, I prefer infraneural approach because I'm so used to doing disc injections. And we know that Camden's triangle is a super safe area. And in that case, the AP is the same, that you don't want to go past the mid-pedicular line. And on the lateral, you don't want to access the disc, presumably. And so I think that the transforaminals are definitely useful, and kind of from the safety and anatomic standpoints, I will say I did brush up on this a little bit. So not to act like I actually remembered all this stuff, but most safe to not do the transforaminal approach above the level of L3. And the reason why is that the artery of Adenkovitz, which of course is the bane of existence for vascular interventional radiologists as well, tends to enter level T12 through L3, less common and more common at L2 and above. And I think I saw around 80% of the time it enters through the left foramen. So just something to be aware of. And so for that reason, I wouldn't do a transforaminal above the level of L3. Some may disagree with that, but I think that that's kind of the most safe thing. So what's been your experience with transforaminals? I think you probably have done quite a bit more.
Yes. So it's a mix. If a patient's having primarily radicular symptoms, or sometimes the orthopedic or our spine colleagues are pretty prescriptive that they would like both a diagnostic and therapeutic transforaminal injection, then we'll move forward with the transforaminal. This is kind of standard operating procedure with us. And we'll do supraneural approaches primarily. If there is for some reason where that area is inaccessible, then we can go infraneural, but primarily we'll go supraneural for the same areas to watch out for. I'm not going to rehash that, but basically I'll start an AP, find the level that I want to go to, crisp out the end plates, and then start rotating the II. So say if we're doing a left transforaminal, then the II is coming towards me. So it'll be coming towards the patient's left. And I'm looking for that Scotty dog. And ideally, and it's not going to happen in every patient, but ideally the ear of the Scotty dog below will bisect the pedicle. And that's when I know I have a good look at it. Now, like I said, it's not going to work out that way in every single patient, but if you could pick a picture, that's kind of the one that you'll find in the textbooks. And then I do kind of a barrel on in approach and go in, still do a loss of resistance technique. And then once I'm there, contrast injection. I'll tell you, one of the other things I'll also do is I'm always torn with these diagnostic / therapeutic transforaminal ESIs. I actually like to have my patients a little bit lighter, only because every now and then, and I wouldn't even say infrequent, but some patients, when I do the injection, either with the LOR or with the steroids going in, I'll ask them if once the steroid has gone in, so presumably I'm finished with the procedure, I'll kind of go to the head of bed. I'll just say, did that recreate your pain? And some of them will say, man, that's exactly where it goes. Or sometimes we have we'll be doing 2 levels and they'll say, the first one I felt nothing, the second one, that was where it was at. And I'll note that and also, make sure that my referring colleagues know that I had that encounter with the patient. I don't have any good literature or follow-up to tell you if then that actually really is the spot. But to me, if either when I'm going in, sometimes you touch the nerve going in, it can set off that radicular pain. And that's a bummer. I don't like that for the patient, but I will ask them if they happen to be griping about it. I'd be like, is that the same pain that you're having? And, sometimes they're like, no, you're just hurting me in a different way. I'm like, okay, good to know. Yeah. We'll finish the procedure and then I'll drop down to the next level. And then my cocktail for these injections is less. So it's a total of 3 mLs of fluid, 2.5 of Celestone, which, if I'm doing the math, is 15 milligrams, and then 0.5 milliliters of bupivacaine.
Nice. Yeah, I would say we use kind of a similar volume for that, based on our cocktail. Mm-hmm. Yeah.
So you're getting a lot more bang for your buck in terms of using Kinalog, because you're at 40 milligrams of steroid. Actually, feels like that makes a lot of sense to do Kinalog, especially with the transforaminal. But for whatever reason, when my partners taught me, we all use Celestone, and so I kind of got brought into that fold. But yeah,
sure. I think that's totally fine as well. So we've talked interlaminars, we've talked transforaminals in the lumbar. Why don't we move over to cervicals and talk about this a bit? And do you do a decent amount of cervical ESIs in your practice?
I wouldn't say a decent amount of cervicals, but I've definitely done some cervicals. I've never done a transforaminal cervical.
Good. And I'll talk about that some. And I will say, sir, in my fellowship, the cervical ESIs, it took quite a bit longer than lumbars to get comfortable with. And cervical obviously is just different for a variety of reasons. I think patients get a little more nervous being worked on their neck than their lower back. The process for kind of teeing them up for this is pretty similar. I would say that most of the cervical epidurals are probably going to be done at the C7 T1 level, just to do it as low as possible. You can go at higher levels, and I think that's fine. But we're still kind of applying that sort of shotgun approach to, if they have a radiculopathy, then a lot of times you can just do a single ESI and then maybe done from there. You can get more specific with it and go more at the specific level, interlaminar. And so obviously the C-spine is quite a bit different from the L-spine. And the way that we would set it up is come AP and start by getting that crisp end plate at the level you intend to go at. And usually that's going to give you a pretty decent interlaminar window. Again, if you're having trouble, you can get some caudal action on that and just open it up a little bit more. And again, you can do the down the barrel en face technique, which is you'd oblique probably about 5 to 10 degrees to one side and just place down the barrel at the level there. And you can also do this just on straight AP, just by starting a little bit more paramidline and then just advancing both ventral and medially as you go. And so that's kind of the way that I learned how to do it. And I think either works just fine. And I think cervical ESIs are honestly really great because upper extremity radiculopathy, it may be less kind of acutely debilitating than most of the true lower extremity sciatica. But I mean, this can really mess with people's ability to function. And so a lot of times, though, you're able to just do a single one and get it gone.
Do you do anything with positioning, like patient positioning, or like what type of table? Like, do you have a table where they can, they have a hole for the face, and so you can get, I think that's like important to like bring their neck out of extension. Like sometimes for whatever reason, there's a lot of built-in knowledge. Like if you're trying to start this service line and just start doing these, like take a look at like how some other people are doing them as far as like positioning the patients either with their arms and with their neck, because that to me like made for either a very difficult procedure or a very straightforward procedure.
Absolutely. Such an important consideration. And we had a table that had kind of a head cut out that you could take out. But actually for these, what we would do is actually keep that pad in there, and we would have them tuck their chin kind of toward their chest. And so you're getting a bit more flexion. As you said, the extension is the enemy in this case because you're going to close off the interlaminar window. And so we get a bit of flexion on there, kind of as much as they're comfortably able to, they can feel like they can do that for a few minutes. And that helps a whole ton. Otherwise, like you said, you are going to be battling some less than optimal positioning.
Yep, totally agree. And for your cocktail, what do you use for cervicals?
So actually use the same as lumbar. And again, this is, to be clear, this is a cervical interlaminar. And so, and again, you can, if they have some stenosis, then I would cut it some, but yeah, literally the same. So it's 40 milligrams of Kinalog, and then fill up the rest to 8 cc's with some combination of bupivacaine and saline. And you can mix and match this. You can do a little more lidocaine to give them some more quick relief, just depending. And so there's different ways you can go. But I would say that the choice of the steroid is something that's really important in the cervical. Do you use Celestone up there as well, or something different?
Celestone.
Yeah. And I certainly think it's totally fine to use dexamethasone. I think that the reason that we would use particulates is that they, last longer. But this is a really important consideration as we talk about the cervical transforaminals. And I'm going to say another thing that this may come across heresy to some of our interventional pain colleagues, but I've been taught this, and based on the data that I see, I just do not feel that a cervical transforaminal, the risk profile is favorable at all. And the reason for that is there have been many case reports of basically brain stem or posterior fossa infarct. Not many, but some. And so the reason why is that the vertebral arteries are really quite close there. And so obviously when you're doing the cervical epidural of the interlaminar, I would say it differs from the lumbar in that you need to do this live, because you can get a false loss of resistance, and you may overshoot and get a loss of resistance once you're in the thecal sac. And that's bad because you may actually be in the spinal cord. So I start doing live a little bit more posteriorly, and the epidural space, it can kind of weird you out. On fluoro, it can be quite a bit more posterior than you think. And so what you're looking for there is a spinal laminar line again. And this looks quite a bit different than it does on the lumbar. And so once I start pushing that, and again, I'm using my contrast LOR syringe, and I would say, because you can get false loss of resistance in many circumstances in the cervical, I would just use the contrast. And then you can see okay, is there vascular uptake? At first, you're just going to get some non-specific soft tissue stuff, but as you push it forward, then you'll feel the resistance go down, and then you'll see the contrast spread out in the epidural space. And the reason why I don't think just doing it purely by LOR is really safe is because the ligamentum is really quite small in the cervical, especially compared to the lumbar. So that would be my approach for that. And sorry, that was a little bit of circuitous talking about the transforaminal. But so the transforaminal, if you're going to do these, which again, personally, I wouldn't advise it. I think that you can do the interlaminar and get just as good relief with it. But if you are, for whatever reason, do not under any circumstances use particulate steroids. And there's been some pretty interesting studies with this. And Dr. Beal had a fantastic presentation that he shared with me that showed they did some studies on basically rat brains. And they saw that with the particulate steroids, there were visible zones of infarct if getting into the vertebral artery. And so obviously you want to be looking for that vascular uptake if you're doing these. If you're going to do them, it's much better to do, you need to do at least live fluoro when you're doing your contrast injection and subsequent injection. DSA, I think, is even better. And so that gives you better specificity for looking for any sort of vascular uptake, which sometimes it can kind of trick you out. The vertebral artery uptake can look maybe a little bit more like the epidural spread than you would think. And so because of the potential for posterior fossa brainstem infarct locked-in syndrome, I mean, you can seriously mess somebody up doing one of these. And so I know there's people out there who feel very competent with transforaminal cervicals, and I appreciate that. But the data that we have shows that there's really no fluoroscopic safety zone for a cervical transforaminal. And that's why I'm not really going to talk about the technique too much for it here. But even if you're doing it technically perfectly, no vascular uptake on your epidurogram and so on, you can still have one of these devastating consequences. And so for that reason, I prefer to stay interlaminar. And I'm happy to share some of these resources and literature with our listeners in the show notes. I think this is a really important thing to consider. And anything to add to that part, Chris?
No. Our practice kind of mirrors yours in that we actually do get referrals for transforaminal cervical ESIs, but me and none of my partners, none of us practice those or attempt them. Like you said, it's just a risk-benefit profile for us also in that it's a small number, but certainly potential devastating consequences, even when like you do everything right. And that's at least for me, that's like a frustrating way and kind of a confounding way to think of a procedure where you're trying to help someone's pain, and you can have a potentially totally devastating, incredibly awful, life-altering
for sure.
Yeah,
so, potentially even fatal, and it could be argued that the non-fatal complications are even worse. Right. And so, just not to get too dramatic, I don't want to beat the drum too much here, but I think it's important that any procedure you're going to do, you have to understand, every possible complication that can occur, and then you and the patient have to weigh this in terms of the risk-benefit profile. And for me, the way that I've been trained, I don't think I'll ever do a cervical transforaminal. And what I will say, people say, well, how do you get more selective than doing just kind of an interlaminar? So, and one thing that I will say to that is most of the time, radiculopathy is due to the disc, as we kind of alluded to earlier, these inflammatory mediators leaking out. And so my approach for cervical radiculopathy would be start with an interlaminar cervical. And a lot of times that'll just kick it and they'll be good, and their disc tear herniation can heal on its own. If that doesn't work, you can do a cervical discogram. And that's something we can get into more later. That's a front approach, going through the front. And we can talk about the technique about that later. And this is kind of interesting when you think about it, because you get sort of an inside out transforaminal, because you inject through the disc. It helps to shut down the inflammation coming from the disc. And probably some of that medication actually goes out and goes into the foramen and helps the nerve root as well. So that would be typically how I would do it. Start off with the admittedly less specific interlaminar CESI, And if they come back, don't get enough relief or not full relief, then you can do the disc injection. Like I said, we'll talk about that on a separate episode because that's a whole, don't get me started on disc injections because I won't stop talking for 5 hours.
That's awesome. All right, good.
Any other thoughts on the cervicals?
I think you covered it well. Like in the cervicals, I think positioning is important.
I remember one thing that I forgot to talk about is the patient's shoulders can be a problem a lot on the lateral.
Especially on the lateral, absolutely.
Yeah, and so especially if you have a patient who has a particularly thick neck, thick shoulders, or just kind of short neck, this can be a problem. And so a lot of times if you're going lateral and you're just like, I can't even hardly see the needle, and have, if you have extra people in the room, kind of pull on their arms to pull the shoulders down. A lot of times that'll give you a beautiful view. Sometimes despite even doing that and with good positioning, you're just going to have a crap view. And in that case, I think going contralateral oblique is kind of the best you can do. And there's a lot of people who love the CLO, and I think that's fine. The one thing that I've been taught in regards to that is you don't have such a great assessment of the depth as a lateral. And so since the depth is so important to me, I prefer, unless I'm just absolutely not able to do it on a true lateral view. And if for anatomic reasons, you just can't get it, then the CLO is fine. Just be very careful as you are getting into the epidural space.
Totally agree. I think the lateral is more crucial for the cervical, and every now and then you run into a patient. I like the shoulder pull, and also, like you said, I think a nice backup when you can't get the lateral shot that you want. It's just COL.
Yeah, for sure. And I would say sometimes you just can't get into the level that you want, and it's okay. It's perfectly
totally
fine
agree.
to kind of pull back and aim for the level above.
Mm-hmm.
And you don't necessarily even need to come back to the AP to do that, but as long as you mind your trajectory and you come back and you just aim for the level above, you're usually going to be okay doing that. And that's totally fine. But I would say 90% of the cervical epidurals I've done interlaminar and at C6-7, mostly C7-T1, sometimes C6-7, and sometimes T1, T2. And that'll kind of get into talking about thoracic epidural injections, which do you do many thoracic epidurals? Or
I've never done a thoracic epidural. Oh, one of the other things I was going to bring up, like with doing the cervical, for some reason, I think a lot of people have more experience in looking at the lumbar spine, but the first couple of caudals, cervicals that I did, I find like counting the levels, like it wasn't always like as straightforward. Like it took me a while to get my like pattern recognition as far as like what T1 looks like and what C7 looks like. I'm having trouble like putting it into words other than like the orientation of.
I agree too. It's very confusing. I think the cervical and the thoracics have more of a kind of homogeneous appearance in terms of one level looks more like the next. So what I always choose is to start from something that looks different. So for me, that's C2. So I can find the DINs and find the lateral mass of C2, then I'll count down from there. To me, that's the most consistent way, because I've had it times where I've gotten faked out where I'm like, okay, I think that's T1. That's the rib coming off there. And then it just due to the angulation, it's not. Of course, a patient can have a cervical rib, different kind of weird things like that. So I would say always count from the top. And so you can get C2 and you can move your C-arm down a little bit if you need to. But I would say always count from the top on that.
Gotcha. One of the other things, T1, I think I'm saying the right terms, but T1, like the transverse processes kind of have like a more cranial orientation, like they go from medial to lateral, like angling up, and then the cervical ones are kind of like going from medial to lateral and angled down.
Yeah.
But I agree. Like I'm kind of a belts and suspenders when it comes to that part. Is I'll count from above, but then when I get to the level that I think I'm going to be at, which is typically C7-T1, I'm looking for that characteristic where the transverse processes are going the opposite directions, like kind of triangling at each other. Yep.
For sure. Great pearl there. And so talking about the thoracic, this is going to be real quick. I would say basically thoracic epidurals, I mean, the indications for them are vanishingly small, but
such a good way
basically
to put it.
A thoracic, just because, it makes sense. The thoracic spine is a more stable place. You tend to have fewer problems with degenerative disc disease, but still the thoracic degenerative disc disease is very prevalent. And sometimes you end up with a radiculopathy. And so kind of an isolated thoracic radiculopathy that correlates with either a high intensity zone or a herniation of a thoracic disc, I would say that's totally fine. You can do a thoracic epidural there. I personally prefer to do a thoracic disc injection. again, that'll be a topic for another time, but it's very much similar to the lumbar. I would say they tend to be a little harder because the interlaminar window is quite a bit smaller. And so you may need some pretty significant caudal angulation just to get in. And again, this is one of those things where it's more of a shotgun approach, doing it with the interlaminar and just trying to get in a good amount of volume to coat that and just kind of kicking that radiculopathy out so that hopefully the disc can kind of heal on its own. But aside from that, I did single digit number of thoracic epidurals, but just based on the practice, it may happen. Some people say, oh, the patient has thoracic pain. Just start off with a thoracic ESI. And that's okay, but I think they're about as effective as lumbars are for solely low back pain.
Sure.
In that case. So I think thoracic radiculopathy, home run, that's an easy time to use TSI, so to speak.
Well, see, what I find interesting about your practice is that the arm, and that's why I think your podcast and the focus on MSK and pain related interventions is so important in that my armamentarium is so much slimmer. And so, the things that you're oh, I'm much more likely to do a disc injection, or I would never even think to do that just because, I just wasn't trained in it. And it's not something that I think to do, or it just kind of reminds me of the people who do interventional oncology. And, I think gone are the days where you're kind of a one trick pony. Now you have to offer the suite of interventions. And so I think that's awesome that, I'm assuming we're going to have some more podcasts and start talking about the disc injections.
For sure.
Super
and
good.
The discs and anterior column in general are kind of neglected. And I think back in the 90s, more discograms were done. And I think they got a bad rap because a few studies came out that I think are, in retrospect, pretty questionable, implying that degenerative disc disease was accelerated with disc access. And then also the boogeyman is discitis. And I will say I've had 0 cases of discitis. I've done probably about 600 disc injections in the last year. And Dr. Beal, my fellowship director, has done tens of thousands at that point, and he also has had 0 cases. The important thing is to use antibiotics beforehand. Again, we'll dive more into that, but I think that having disc injections to work hand in hand with your ESIs is a very powerful tool. I'll just say that as a preview. And so the disc injection interlaminar ESI combo is awesome for treating both radiculopathy as well as primarily back pain with a little bit of leg pain as well. And so we'll just throw that out there. And we will have more conversation about disc injections again very soon. And that's something that we hope to get out there because I think it's just one of these areas that even in interventional pain, I think most of the people who are training in modern interventional pain fellowships, most of them don't have much, if any, experience with disc injections. And it's something that's relatively easy to add on. It's very satisfying and extremely effective. Out of any of the injections I've learned to do in my training, it's by far the best. And so that's something that we'll talk about. But ESIs, obviously very common. This is a bread and butter type of thing. And personally, I feel that this is something that IRs are really well equipped to throw into their practice. And so, using good resources like the Furman Atlas, this podcast obviously being the best resource of all time. No, I think that this is definitely within the wheelhouse for IRs, and hopefully this helps some of our other colleagues in other specialties as well. And would really like to hear hopefully hear some other perspectives in the coming weeks after this, because, everyone with epidurals, it's so many different ways to skin a cat, different preferences. You and I have slightly different techniques just based on how we learned it and different preferences. And so I hope this will be very useful to our listeners.
Oh, one more thing I wanted to touch on before we wrapped up, and it's straightforward, but how do you handle patients in post? How long do they stay? Do they have to meet any criteria before you bounce them? And then, I was interested to see how you counsel the patients afterwards, as far as when do you expect relief? Do you have a lull in your symptoms? I think there's a lot you can do here. Within a short amount of time, you can cover a lot of ground in post. That's important.
Yeah, for sure. I think that's really important. I think I have done most of the counseling before the procedure, but also good to swing by and see them after and kind of remind them, because repetition is the key to adult learning. And some people just kind of have to hear things multiple times. And so let them know, you should start getting some, usually within half an hour with the bupivacaine. they get some pretty solid relief, and that will tend to maybe increase a bit more over the course of the day. And it's important to let them know if you're using the anesthetic as well as a steroid, they're going to have sort of this bimodal relief, right? So that first is kind of the anesthetic, and that'll wear off either within that day or maybe over a couple days. And then really more of a week or so to get the rise of the effects from the steroid. So important for them to be aware of that. And as we've said multiple times, it's very difficult to predict how somebody will respond to it. And, in terms of the durability of the response. And so it's very patient by patient. And so I kind of talk to them, as I learned from Dr. Beal, sort of an algorithm for their individual treatment. What will be the next step? And a lot of times that's going to be maybe a disc injection, or there are some other interventional therapies, depending on whether this is stenosis or disc related. And depending on the patient, a surgery might be something that's down the line, or it honestly may be the next thing for them, just depending on their different factors. But I think it's really good, just kind of remind them, okay, you're going to have sort of this relief of pain. It's going to probably come back a little bit, and then it's going to get better as that steroid kicks in.
How long do you keep the patients? Like an hour, or till the anesthesia wears off?
Yeah, I would say, exactly.
Yeah,
probably about 30 minutes to an hour. So if I were doing this in the hospital, I would just kind of say, per whatever recovery protocols, And obviously, as we talked about earlier, things get a little bit different if you unfortunately get a motor block. And
totally different.
Just be a little bit more involved with the patient, kind of go through those, try to stand them up, and if they have just kind of pain, and then you can walk them around and do that kind of thing. But basically, as soon as they feel ready to go, and of course, they need to have a driver if they've had moderate, which I would recommend. That's pretty much it. So we don't need to watch them a whole lot. One other thing that which probably bears mentioning is just kind of bleeding risk and stuff like that. So there's some really great. We have one from SIR, kind of a bleeding risk, and holding anticoagulants, antithrombotics, and ASRA also has a great app for this too. And I think because they're more focused on pain procedures, that's the one I actually use the most. And I won't get into specifics because I'm the type of person I have to look at the kind of the list every single time, because I don't trust myself to remember, it's 5 days for this or whatever. And so, but epidurals is one of those ones where technically it can be said to be a high bleeding risk, because complication of an epidural hematoma is devastating. So I would say be very careful, buy the book on that. And if you're planning to do an LESI and the patient, they took their high dose aspirin, one thing that you can do, and that we didn't really get into earlier, was the Caudal ESI. And Caudal is, I've done very few of them so far, but it's good to have in your toolkit for situations like this, either maybe an anatomic reason in the lower lumbar, or this kind of situation where the patient is on, anticoagulants or antiplatelets and they can't come off, or they didn't come off. You can still do this. And basically the way you do that is you palpate the sacrocornua, cornu, and which is going to indicate where the hiatus is. And you're going to kind of start your trajectory a little bit below that, and then pretty much instantly go to lateral. It's difficult a lot of time to appreciate the cornu on the AP. And so you get more on the lateral and you kind of see that. And this can be quite tricky depending on the patient's sacral dorsal tilt. And so, but it is one thing that you can do. And I would say, once you get into the epidural space from below, you just inject and then you should be good to go. Some people will advance a catheter from below, and that's a cool thing to do. But I would say that you definitely don't want to really go above the level of S3 with your needle, because the thecal sac should be ended by S3. And so that's one nice thing. You can go to the caudal, because even if something bleeds in the caudal epidural space, it really doesn't matter. Whereas doing an interlaminar LESI, if you get a dorsal epidural hematoma at L3-4, that could be pretty significant complication.
Yeah. Actually, talking about caudals brought something back to me. For some reason, I said earlier I wasn't really trained in ESIs, but there was actually a place that we went to and we did not a lot of ESIs, but every now and then they would come up. But the preference was to do caudals. And so I actually did a fair number of caudals. I mean, not a fair number, but I don't know, maybe 20 or 25. And the caudal it's kind of its own beast, but you basically start in the gluteal cleft or the bud crack, and then you just kind of like, you're almost like pointed like straight cranial, and then like you're in the lateral position, you find that little gap. I don't even know what it's called. What's that called? This caudal
the hiatus.
Okay,
the
sacral hiatus.
The hiatus, and then the part around it is called the cornu.
Yeah, and then when you find it, like it's not too hard to find in some patients, but like you kind of just poke around and you feel it, and the needle slips in, and then you stay below L3, and then that's right. It's all coming back to me now. I just remember like doing those, and it felt strange because like you really do start it in the gluteal cleft, and like you're just aimed like, I mean, it's just, you're not aimed like, from anterior to posterior or posterior to anterior. It's really, you're aimed straight up. And so, I remember those now.
It's a very, very significant steep angulation. And so that's one thing that takes getting used to. And sometimes, I mean, you literally are starting at as low as you can go to get in there. So I'm not a big fan of caudals. I don't do that routinely, but it's certainly something that's good to have in the toolkit. Well, awesome. I think we covered just about every type of epidural. I think it's been a great conversation. I hope that people get a lot out of this, and I appreciate your time, Chris. I know it's late over there in Paris.
Nah, dude, I got all the time in the world for backtable stuff.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable MSK on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Janelle Kennebrew.
Thanks again, and see you next time.